Hello, everybody. Welcome to Global Response to COVID-19. This is webinar number 17. This meeting is supported by the Panamerican Trauma Society, the American Association for Surgical Trauma, International Relations Committee, the World Coalition for Trauma Care, and by University of Miami and Virginia Commonwealth University, VCU. I would like to welcome all the participants, the panelists, and the presenters. And I would like to show now today's presenters. So our panelists today are going to be Dr. Enrique Ginsburg. He's Professor of Surgery at the University of Miami Miller School of Medicine, Trauma Medical Director at the Ryder Trauma Center at Jackson South Medical Center, and Vice Chair of Surgery at Jackson South Medical Center, Miami, Florida. We're going to have Dr. Camilo Ricordi. Dr. Camilo Ricordi is Professor and Center Director of the Diabetes Research Institute at the University of Miami Miller School of Medicine, Miami, Florida. Dr. Raul Coimbra may join us later, Executive Director of the World Coalition for Trauma Care, Surgeon-in-Chief at the Riverside University Health System Medical Center, and Professor of Surgery at Loma Linda University School of Medicine. Dr. Felipe Vega, President of the Panamerican Trauma Society and Trauma Surgery Department of Surgery at Hospital and Lomas, Mexico City, Mexico. Moderators, Dr. Michel Aboutanos, Professor of Surgery and Chief of Division of Acute Care Surgery Services and Medical Director of VCU Trauma Center, Virginia Commonwealth University Medical Center in Virginia, USA, and myself. Dr. Thomas Scalia was going to be one of the presenters today. Dr. Scalia, Panamerican Trauma Society Executive Director and Professor of Surgery at the University of Maryland School of Medicine and Physician-Chief of the Adams College Shock Trauma Center, Baltimore, Maryland. I had a family issue, and unfortunately, he's not going to be able to present today. And then Dr. Gerd Pust, they're going to present some data from the Ryder Trauma Center, Miami. Dr. Gerd Pust is Associate Professor of Surgery at the University of Miami Miller School of Medicine and Director of Surgical Intensive Care Unit at the Ryder Trauma Center, Jackson Memorial Hospital, Miami, Florida. Another presenter is going to be Dr. Francesco Vaia, Chief Medical Officer at National Institute of Infectious Disease, Lazzaro Spallanzani in Rome, Italy. Valeria, please show the slide with all the associated entities and medical societies that have been with us for 17 weeks. So the Panamerican Trauma Society, the World Coalition for Trauma Care, and the American Association for Surgical Trauma, International Relations Committee are very proud to have all these medical societies from around the globe joining us and share their expertise within the management of COVID-19. So now, everybody in this meeting agrees to be recorded. This meeting is being recorded, and the link for this meeting is going to be available at the Panamerican Trauma Society website. I would like to ask Dr. Camilo Ricordi to please introduce our speaker from Rome, Italy, give a brief introduction of Dr. Francesco, and then Dr. Francesco will start his presentation. Dr. Ricordi, please.
And Francesco, then you can unmute yourself. So it's my privilege to introduce Dr. Francesco Vaia, who is the Chief Medical Officer of the National Institute of Infectious Diseases, Spallanzani in Rome, Italy. And I ask Dr. Vaia to please help us present because I'm also serving as a member of the Supreme Council of Health in Italy in Rome, and one of the challenges that, as you know, has been the transmission and infection of frontliners, healthcare workers, and doctors and nurses. And Spallanzani has been leading Italy, being the one of two hospitals who never had an infection, never had a COVID positive among healthcare workers, doctors, and nurses. So that I thought maybe you could share with us some of the strategies that they're implementing as we are learning about this virus along the way. So, Dr. Vaia, thank you for joining us and giving your time. And I'll try to do a semi-instant translation of as needed.
Thank you, Professor Ricordi, grazie. Grazie per il privilegio e per l'onore che mi fate di parlare in questo vostro webinar. Il tema che mi era stato assegnato è sì, ok. Il tema che mi era stato assegnato in questo momento è di riuscire a spiegare in poche parole in che modo un ospedale importante che si occupa di malattie infettive è riuscito a stasera ad avere 0 contagi in tutto il personale sanitario che opera in questo ospedale.
So the theme, as we mentioned, is how this hospital succeeded in having 0 transmission of viral transmission among healthcare workers and physicians and nurses at Spallanzani Hospital in Rome, and strategies that could be used to minimize the risk of viral transmission for physicians and healthcare workers.
Io ringrazio il professor Ricordi e ringrazio voi per la pazienza, ma parlerò in italiano perché ci metto tanta passione nel raccontare questa mia esperienza, che ritengo un'esperienza veramente molto importante, che ha preso anche dentro la mia vita.
Sorry for speaking in Italian, but there is so much enthusiasm and energy in describing this very important experience that took so much of his professional life in this unprecedented pandemic. But I'll try to translate.
Allora, il tema che abbiamo davanti a noi è, rispetto agli stakeholders, i lavoratori della sanità, i cittadini e i pazienti, come è possibile che non ci siano infezioni crociate.
So the theme is how to avoid cross-contamination between the people in the society, the patients and the healthcare workers.
Perché ciascuno di questi soggetti, o lavoratori, o cittadini, o pazienti, possono autonomamente diventare degli untori e far diffondere il virus in tutta la popolazione.
Because all 3 compartments of the population, patients, people and healthcare worker, can become themselves the spreader of the virus and contribute to the dissemination of the infection.
L'ospedale è una struttura particolare, per cui è capitato in Italia che alcuni ospedali, del nord Italia in particolare, si sono trasformati in incubatori della malattia e successivamente in diffusori, per cui gli operatori di sanità sono diventati paradossalmente vittime ma anche protagonisti, perché hanno infettato intere popolazioni. Questo per esempio nell'ospedale di Azzano Lombardo nella Lombardia, nel nord d'Italia.
Is making the example on how this has been paradoxically one of the major problems in Italy, especially in northern Italy, where some of the hospital became the main element of spreading of the virus throughout the population, because they didn't have proper means and standard operating procedure and strategies to contain and prevent this spread through compartmentalization of the infrastructure and the people working there.
Per cui quando il 29 gennaio si è presentata qui allo Spallanzani la coppia cinese ormai famosa nel mondo, che qui è venuta e che qui è stata curata e che qui è guarita, e qui abbiamo isolato per la prima volta il virus sulla coppia cinese, in quel momento ci siamo interrogati rispetto a questi 3 stakeholder e abbiamo detto: bene, come facciamo per far non diffondere il virus? È stata la nostra prima domanda.
That was when the first couple from China arrived at Spallanzani, that is the couple where they isolated the virus eventually, was the first question that they raised, is how to prevent the spread of the virus across these 3 compartments, and they started implemented strategies in this direction.
Ora, questo virus che voi adesso avete in fase crescente, se ha insegnato una cosa a tutti gli operatori, a tutti gli scienziati, è che si è presentato in una maniera mai omogenea. Cioè noi oggi, ancora ad oggi, siamo in una fase strettamente empirica. Non possiamo dire che c'è un percorso regolare, per cui molte cose si sono fatte strada facendo, appunto per steps, man mano che conoscevamo questo virus e le azioni da mettere in campo per contrastarlo.
So this virus has triggered an empiric pathway of experience, because nobody knew exactly how it was working. There were mixed messages at the beginning, so is on the pathway as the pandemic progressed. The strategies that have been implemented has been mainly implemented as an empiric pathway.
Per cui abbiamo proceduto per steps e che hanno investito sia la parte strutturale dell'istituto, dell'ospedale, sia nell'incrementare, nell'immettere nuovi diciamo, presidi, nuove regole, ma soprattutto nuovi presidi che difendessero i lavoratori.
So they implemented step by step this empowerment of healthcare workers and strategies to protect healthcare workers.
Quali sono i cambiamenti strutturali? Il primo, più importante, è cambiare il layout dell'ospedale.
So
allora,
the structural changes was to change the layout of the hospital.
Qui alla vostra sinistra, alla sinistra di chi guarda lo schema accettazione è scritto, no? Qui. E l'ospedale come era prima del Covid, con un percorso normale tu vai in ospedale.
The left panel you see the admission, how it was in the hospital before the Covid pandemic erupted. And on the right side.
Ok, dopo la pandemia, la prima, the first action, la prima azione da mettere in campo è isolare completamente il percorso che diventa sempre one to one. Una persona, una tenda. Qui c'è una tenda grande con 5 postazioni. Ad ogni postazione c'è una sola persona o contagiata o sospetta, ma sempre una sola persona con un percorso assolutamente dedicato dall'esterno.
So the first strategy was to implement these tents outside of the hospital where you could do the screening of people either with COVID or suspicious to have COVID, and always one person at the time and one person per position. So in this case, on the right lower figure, you see a large tent. This had up to 5 screening stations, well separated one from the other, but always one person at a time.
Perfetto, perfetto. Quindi noi abbiamo praticamente la prima cosa importante in questa fase, anche se è una fase diciamo iniziale, la prima è dividere rigidamente i sospetti o persone già Covid da altre persone, anche se avevano altre malattie infettive. Quindi percorso assolutamente rigido che si sviluppa tutto dall'esterno, come vedremo successivamente.
So the pathway was completely separated from COVID patients and non-COVID other pathologies, as we'll see in the next steps.
Ok. Ora, come vedete qui meglio, i primi cambiamenti strutturali che accennavo prima. Percorsi obbligatori separati. Io vado da lì tutto dall'esterno, che è differente sia per i pazienti sia per i lavoratori che si occupavano e che si occupano di Covid. Cioè non esiste una persona che si occupa del Covid e di anche non Covid. Sempre, abbiamo detto, il senso è one to one. Un operatore, un paziente, malato o sospetto di Covid, un operatore o a questo punto più pazienti non Covid. Ma importante è che un operatore strettamente dedicato al Covid, già affermato, conclamato, positivo o anche solamente sospetto, perché oggi come ieri i sospetti sono i più importanti, perché sono tra presintomatici e sintomatici ben il 50%.
So pre-symptomatic and asymptomatic are 50% of the spreader. So it's very important to separate the external pathway to access to the structure. There are different pathways for health workers and patients, always one-to-one, one patient, one healthcare workers, and a COVID healthcare workers cannot see patients that are non-COVID. So it's dedicated access for the ambulances for COVID and a completely separate pathway with external access to the area COVID or non-COVID, keeping them very well separated.
Oltre alle aree, Camillo, il personale dedicato esclusivamente a Covid.
Besides the area, yes, as I said before, the personnel is dedicated to COVID. So physician or nurses taking care of COVID patients don't have any contact with other patients that are non-COVID.
Un altro provvedimento fortemente voluto da me e ancora diciamo, presente sembra una sciocchezza, Camillo, ma lo devi spiegare bene questo. L'accesso negato ai media e ai visitatori sono due cose importantissime, che tu immagina, lo devi dire bene questo, che quando sono venuta la coppia cinese, tutto il mondo, tutte le televisioni sono venute qui e tutti volevano fare il film, il cinema qua dentro, capito? Farlo diventare un set e io l'ho bloccato e ancora ho bloccato. Mai nessuno è entrato in questo ospedale.
So the other very important things is that they block completely the access to press and visitors in the hospital, because as you can imagine, when the first Chinese couple was admitted and all the press and television from all over the world wanted to access the hospital and do interviews and film. So it was still now, he's keeping very firm this policy of access denied to press and visitors.
Cioè, per far capire plasticamente, è come se tu avessi una bolla sopra l'ospedale, capito? Cioè tu vieni dall'esterno e dall'esterno sei un sospetto, entri in questa bolla che è una bolla di asetticità, capito? Cioè tu entri in un ambiente che è assolutamente incontaminato e quindi tu che vieni da fuori, vieni qua, vieni pulito, con vieni, come dire, hai tutti i presidi che noi mettiamo a te, come vedremo dopo, e al personale, quindi entri in questa bolla nella quale è difficile che tu possa contagiare. Quindi c'è uno strettissimo e rigidissimo separazione da questo mondo dal mondo esterno. È una cappa, dentro una nuvola siamo, dentro, e poi parleremo del nostro amico Fuchs dopo, della nuvola.
There is like a bubble. It's like, if you can visualize, you create a bubble around the hospital that completely separate the external world from the inside, so that you prevent contamination from the inside to the outside, and there is a very, very strict attention to this separation.
Sì. L'ospedale, l'istituto, ha avuto poi un percorso di reingegnerizzazione, perché accanto alle regole, accanto alle disposizioni, c'è stato poi tutta la riorganizzazione dell'ospedale in maniera flessibile.
So there has been a complete transformation and reorganization, re-engineering of the hospital in flexible ways.
Ok, e praticamente che significa flessibile? Come una regola di mercato. Man mano che cresceva la domanda si adeguava l'offerta, per cui noi abbiamo incrementato i posti letto da 150 ad oltre 350, i posti letto di terapia intensiva, importantissima, presidio terapeutico, la terapia intensiva, l'ossigeno, le abbiamo incrementato da 15, quasi 15 a ben 55 posti di terapia intensiva.
So they increase the flexibility depending on the demand of the beds of the hospital from 150 to over 300 and ICU from 15 to 50 beds.
Praticamente abbiamo assunto da subito il ruolo di responsabili della rete, del network, siamo stati subito il riferimento della rete, abbiamo aumentato i posti letto e siamo diventati, come dicevo all'inizio, questo lo devi spiegare bene Camillo, io ti ho detto che siamo nella fase empirica, man mano che crescevano e quindi la capacità di un manager sanitario è di capire cosa sta succedendo e di adeguare la tua organizzazione.
So the capacity, the important role of a leader in health is to, as you go through this empiric phase, is to understand how the situation is progressing and adapt your structure and organization and infrastructure to the needs.
Quindi aumento dei posti letto, diventare il riferimento di tutta la rete regionale, aumentare i posti letto in degenza ordinaria, aumentare in maniera drammatica, corposa, i posti letto di terapia intensiva e soprattutto diventare ospedale only Covid, solo Covid hospital. Ancora oggi noi siamo the first Covid hospital in Rome.
So the transformation went from increasing the beds, increasing the ICU, to becoming an exclusively COVID hospital that is still now in Rome, the exclusive COVID hospital.
Tenete a mente questa immagine perché questa poi sarà lo sviluppo futuro del nostro ospedale.
Keep in mind this image because it will be the future development of the hospital.
Una cosa da dire subito, però voi vedete i numeri lì 5, 6, eccetera. Quelle stanze, se riesci a dare per cortesia Camillo il senso di questo, sono stanze che ospitano 2 posti letto di terapia intensiva, ma è un alto biocontenimento e praticamente sono stanze a pressione negativa nei quali è impossibile, sono nate per il bioterrorismo e noi le abbiamo adesso adeguate al nuovo terrorismo, alla nuova nostro problema mondiale che è la pandemia da Covid. Noi in quelle stanze è impossibile contagiare o essere contagiati.
So in the room of the intensive care units that there is in all negative pressure, this was a strategy that was born for bioterrorism, but in this new form of bioterrorism in the COVID pandemic, they have practically bubbles of isolation in negative pressure where it's impossible to become infected or to spread the contagion.
Okay. Questo come sarà in prospettiva, adesso voi non lo vedete bene, mi dispiace, anche perché il maestro non ci ha dato il suo via libera. Noi abbiamo, per gentile concessione di uno dei più grandi architetti del mondo, che abbiamo l'orgoglio di...
Abbiamo pochi minuti, Francesco. Perché...
pochi minuti. Questa la devo dire perché è importante. Scusami. Quanti minuti ho?
3.
Vabbè. Me ne date 10.
10. You can have more time. You can have more time. You're fine.
Ok, ha detto che sono un quarto d'ora.
Yes, you're fine.
Thank you. Allora, questo noi abbiamo la fortuna di avere in Italia un grandissimo architetto che si chiama Fuchsas, che ci ha regalato un progetto meraviglioso che sarà più bello, per chi conosce la nuvola di Roma, sarà ancora più bello della nuvola, che dice 2 cose. Che l'incontaminato è luce, per cui sarà come dire, puro, azzurro, diafano e sarà soprattutto svetterà verso l'alto rispetto alla pesantezza della malattia e dentro sarà veramente un Innovation Smart Center perché sarà centro di studio oggi già del vaccino che sperimenteremo nei prossimi giorni e degli studi clinici di fase 1, 2 e 3 e sarà il centro della lotta alla nuova emergenza che sarà la lotta all'antibiotico resistenza e ai germi patogeni multiresistenti.
And so thanks to this great architect Fuxas that is donating this project, will become a smart center and will open a new building of innovation and smart center where there will be not only the development of the vaccine, but also studies on antibiotic resistance and other big challenges facing humankind today.
Vado più velocemente. Allora, quali sono i presidi che abbiamo dati per il personale? Intanto abbiamo aumentato quasi di 1/3 il personale medico, degli infettivologi, il personale degli infermieri e, attenzione Camillo, per cortesia, questo dallo bene, il personale ausiliario, perché abbiamo posto grande attenzione, perché siccome la malattia prendeva e prende molti gli anziani e le persone fragili e coloro che hanno le patologie cronico-degenerative, io ho voluto fortissimamente assumere molti auxiliary nurses, che non so in America come si chiama questa figura, che sono quelli che praticamente sostanzialmente si occupano proprio delle cose minute, come sistemare meglio il letto il paziente, come orientarlo, come farlo scendere, come dargli, insomma, le persone proprio dei veri caregivers dentro all'interno dell'ospedale. E poi, quindi la prima, poi la seconda, aumentare di moltissimo tutti i presidi di protezione per tutto quanto il personale e poi ancora fare grande formazione per tutto il personale per i presidi, come vedremo dopo.
E quindi hanno impostato non solo l'aumento di medici e di nurse specializzate, ma anche molto il personale. Sorry, I was talking in Italian.
Sì, sì.
In the number of physicians and nurses, they put a lot of emphasis on increasing the auxiliary personnel and healthcare workers that are helping, especially because the population was mainly older people or with comorbidity, needing a lot of attention to little details, so that they improve also the availability of PPEs for all healthcare workers and also a lot of training courses for all healthcare workers.
Ringrazio Camillo, si è lasciato prendere anche lui dalla passione, parlava in italiano. Ok, qui come dire, abbiamo queste le raccomandazioni, ma non sono raccomandazioni, sono strict recommendation. Perché qualcuno mi ha detto in americano basta dire recommendation, in italiano devi dire sono proprio come dire, prescrizioni fortissime, sono quelle che conosciamo tutte, quelle di igiene, le disposizioni organizzative, le cliniche e i video di formazione, e adesso ve li dirò molto rapidamente. Vuoi dirlo questo?
These are the guidelines that are very strict regulation to be followed that are everybody knows this, like mandatory hygiene, organizational disposition, clinical training videos for healthcare workers.
Ok, questo per tutti sul sito web, per i cittadini e per i dipendenti. Ok. Questo sono i DINE, per esempio, a tutti quanti, anche con, come vedete, anche dei cartelli, eccetera, ma questo lo conosciamo tutti, no? Come
yeah, so you have signs and things explaining all the people entering in the hospital.
Sì, praticamente come si entra in ospedale, la sorveglianza, la misurazione della temperatura, il triage, l'igiene delle mani, che non ci sono i visitatori e solamente alcuni piccoli entry points, limitati entry points. Quindi questo è spiegare i principi che ho detto all'inizio, no? Come restringere sempre di più. In ospedale si è entrato quasi come in un imbuto, in cui era facilitato l'accesso solo al paziente.
Practically you limit the entry points. You can consider the hospital like a funnel where once you enter is like one by one, no visitor, and then you follow the things that you can read in English in the slide.
Ok. Questi sono, diciamo, gli ordini, le disposizioni che ho dato man mano, ve le faccio vedere a questo punto rapidamente. Allora, questo è importante, però ci tengo. È stato strettamente vietato, mi dispiace moltissimo, ci sono delle persone che hanno visto i propri genitori morti e non l'hanno potuti vedere, però se i parenti, che i visitatori, che i givers non sono mai potuti venire, però ci sono state delle azioni vicarianti, come abbiamo dotato i pazienti di iPad per poter parlare poi a distanza con i propri parenti. Ovviamente i nostri medici sono stati formati ad avere comunicazioni dirette per telefono, per email, insomma sono stati veramente molto molto carini i nostri medici, i nostri infermieri, però come dire, hanno cercato di alleviare questa sofferenza, ma io non ho voluto e non voglio che venissero in ospedale.
So they maintain complete separation, avoiding visitors and relatives or caregivers to join the patient, but they also provided them with iPads and visual things to facilitate communication, to remain in touch. But that was a very important rules that they keep enforcing.
Qui vabbè, insomma, quindi ovviamente sono l'equipe, eccetera. L'uso, come dire, dei presidi è stato importantissimo, perché i nostri operatori sono stati formati sul corretto uso, perché i pazienti, e come anche i pazienti, mettere le mascherine, perché i pazienti erano potenziali diffusori delle infezioni. E quindi, come vedete da questa foto, che è abbastanza, perché ci sono tutti i presidi, voi vedete, dalla mascherina chirurgica al papra, insomma, al presidio dal più semplice al più complesso. Quindi questa foto serve anche per questo, mette insieme
Picture depicts all the different kind of protection, from the more simple to the more complex and complete protection, depending on where the workers are.
Ok. E qui ci sono un po' tutte le disposizioni, no? Ma queste ormai le conoscete tutte. Vado in mezzo a queste disposizioni perché diciamo, tra le cose più importanti, a seconda di dove era posizionato e dove è posizionato l'operatore, tu utilizzi la mascherina chirurgica, oppure FFP2 o FFP3, oppure utilizzi gli occhiali, e soprattutto è importante che il paziente abbia sempre abbia sempre la maschera, perché è un potenziale, diciamo, produttore, no? Diffusore di malattia. Ma un'altra cosa importante è come dire, sui wear disposable gloves. Io ho scritto one pair of gloves for each action. Ci tengo a sottolineare questo. I guanti sono veramente monouso. Monouso significa una sola azione. Anche io adesso metto le mani qua sopra, poi se vado, già se le metto un'altra parte, non sono più buoni. Sono monouso, significa una sola azione per il paio di guanti, una sola azione, se no diventano anche loro diffusori. Importante questo.
Important, besides all the things that you read on the slide that are done in all hospitals. So this doesn't distinguish why you didn't have transmission. But one thing that is important that they strictly enforce is that the gloves must be changed after every action, not like after half an hour or 1 hour. After every action, like you touch a floor or a surface, you change gloves immediately after. So one action, one pair of gloves.
Questo noi l'abbiamo fatto per i nostri diciamo, lavoratori. La guida, questo è importante per la vestizione e svestizione, perché come proteggi il tuo personale? Lo proteggi facendolo vestire bene, e quindi gli abbiamo insegnato come vestirsi, non solamente, ribadisco, questo è importante, non solamente i pazienti positivi, ma i sospetti a quel 50%, ok? I sospetti sono importantissimi perché sono fonte di diffusione del virus.
So they particular attention is taken to train people on how to do proper protective equipment, and also how to consider always suspect patients, not just the positive one, because 50% of the spread occurs through suspect patients not yet diagnosed as positive.
Importante che tutto ciò che dopo viene utilizzato, i camici eccetera, venga smaltito nei rifiuti a rischio infettivo e non nell'indifferenziato o nel, diciamo, come si dice, nella rifiuti comuni, non so, insomma.
All PPEs get disposed in the biohazard bins and not in the undifferentiated trash. And the
rischio infettivo.
is
together
with the gloves.
Ok. Vabbè, qui ovviamente come pulire le superfici, ma insomma ormai questo lo sappiamo tutti in tutto il mondo. Ok, qui anche una cosa importante, come abbiamo consentito, senza chiudere all'interno ma solo all'esterno, come consentire che le aree di ristoro, quindi il bar, la mensa, venissero utilizzate. Una persona alla volta, distanziate, con l'igiene, con la mascherina, tutto da asporto, e quando invece erano seduti a distanza e uno solo per il tavolo.
The hospital maintain the distance and from the area, from the cafeteria to all the area, you always have the signs and maintain distance of all healthcare workers throughout the hospital.
Ok, e anche questo nella sala conferenze, noi qui abbiamo sempre avuto, soprattutto all'inizio tutti, vedete, dal Presidente del Consiglio ai ministri, un po' tutti quanti eccetera, e qui è quando insomma all'inizio eravamo in tanti, poi subito dopo, come vedete, c'è il distanziamento, si vede la differenza tra una sala, diciamo, abbastanza piena e una sala vuota.
You see from the left to the right how was before and how is now, like you keep also during conferences with the minister, Congress people and authorities, you keep always distance.
Ok. Queste sono, diciamo, la sorveglianza interna che è per il nostro personale. Allora, il nostro personale che sta a casa può essere non sintomatico o sintomatico, il personale che è stato potenzialmente esposto ad un paziente, diciamo, positivo, ok? Perché abbiamo ovviamente tanti pazienti, tutti positivi, e quindi il nostro personale è chiamato a fare autodiagnosi, a controllarsi. Se un non sintomatico sta monitorandosi da solo per 14 giorni, poi chiama il medico competente, e se il medico competente gli dice no, che è tutto negativo, torna al lavoro. Se invece è sintomatico, vabbè, vai.
The same structure that we have. If you're not symptomatic but you have been exposed, you do self-monitoring 14 days. You can read the slides, I don't need to waste your time.
Se invece era sintomatico, c'era tutto il triage clinico, ma soprattutto fare il PCR, fare il tampono naso-faringeo, e in caso di negatività ovviamente tornava al lavoro dopo 14 giorni come prima, come quello di prima, avendo comunicato al medico competente eccetera, quindi comunque rimaneva 14 giorni, rimaneva perché noi non abbiamo avuto nessuno, ma sarebbe rimasto, ecco, mettiamo un condizionale, a casa 14 giorni, se invece era positivo andava isolato e poi, se necessario, in presenza di sintomi importanti, veniva ospedalizzato.
These are all the same steps that we do here. Is, if you're symptomatic, triage, swab, and then if positive, isolation at home or hospitalization if necessary. Queste sono le stesse cose che si fanno qui. Ma
certo.
Avete qualche trucco in più? La ragione mi interessa di questa talk è come mai non avevate avuto contagi. Perché molte di queste cose sono fatte da tutti.
E probabilmente non sono fatte. Poi questa è la risposta.
Sarà le camere, la pressione negativa, per esempio.
Che può essere anche quella. E quindi noi abbiamo fatto, però ti dico, questo è importante, noi abbiamo attivato un testing strategy, una sieroprevalenza su tutto il personale sanitario di tutti gli ospedali di Roma e del Lazio, delle forze dell'ordine, polizia, vigili, guardia di finanza, tutti, eccetera, un test di sierologico endovena oppure da capillare, e in caso di evidenza di sopra il cut-off dell'IgG o dell'IgM abbiamo fatto il tampone nasofaringeo. Quindi il personale sanitario è ancora continuamente sorvegliato. Non sfugge, cioè una delle risposte è questa, e tenerli dentro la rete della sorveglianza, capito? Tenerli in questa bolla. E non sfugge.
All the personnel there is surveillance and testing for everyone, every healthcare worker, but also police and employees and cleaner, food service, everything.
La mia collaboratrice giustamente mi dice, quando parliamo di health workers, parliamo anche di tutti i servizi, non solamente del personale, diciamo, strutturato, sanitario, ma anche personale di mensa, personale di manutenzione, personale di pulizia, tutti coloro che in un modo o nell'altro vengono all'interno.
When you speak about health worker, it's not just the medical personnel or nurse, it's all the cleaner, food service, waste operator, guardians, everyone gets tested.
Vabbè, queste sono iniziative, diciamo, un po', no? E ovviamente non le fatte da me ogni tanto, insomma, che ricorda. Insomma, essere sul pezzo, si dice in Italia, no? Essere sul pezzo, ricordare, costanza, come si traduce in americano, essere sul pezzo, ricordare costantemente queste regole, eccetera. Ok?
To be very proactive and remind these rules constantly to everyone.
Questo, per esempio, una cosa che in questi giorni è molto presente. Tu mi hai fatto una domanda, io voglio cercare di rispondere a quella domanda, perché il virus va cercato e va chiuso, va circoscritto. Quindi c'è una proattività. Noi siamo andati l'altro ieri, avete sentito, in aeroporto, perché venivano alcuni da Bangladesh, e siamo andati a fare i tamponi, abbiamo fatto 270 tamponi, abbiamo trovato 36 positivi.
So they go proactively searching for the virus also outside the hospital. Like, for example, yesterday they went to the airport, the unit from the hospital, to do swabs to people arriving from Bangladesh, and they found 36 positive subjects at the airport, deploying the units for testing also outside the hospital in area that are at risk.
Allora, io coordino, no, quest'area regionale.
Siamo a 45 minuti dei 15 che ci avevano dato all'inizio, e poi non possono parlare più gli altri speaker.
Ok, ho chiuso. Ringrazio, tutti, ringrazio, stiamo aspettando di essere ormai uno ospedale normale, non più solo Covid. Ringrazio in particolare il professor Camillo Ricordi per essere stato così carino e cortese. Ringrazio di nuovo voi per la pazienza di avermi ascoltato.
Thank you, Dr. Vaia. And I don't think we have time for a question, but maybe we can discuss with the panel, Antonio, later. But to me, like the main thing is like infrastructure and resources is like the negative pressure room, having all the intensive care units beds in negative pressure. Like we are exposed constantly in most units. Like at Jackson South, I think we have one negative pressure room in the whole. In the tower 2, but in the CCL we don't have so maybe it's a question also on how resources are available to isolate and prevent this cross-contamination.
Yeah, Dr. Ricord, thank you, Dr. Francesco Vaia. Please stay connected. So I'm going to have a short presentation of the situation in Miami. They're going to have a lot of time for discussion. You for sure going to have a lot of questions for you. We are doing exactly what you are doing, but we have infection. And I know that in Milano, or for the previous presentation, they had a lot of healthcare professionals infected and they died. So I'm going to have the presentation from Dr. Pust from Miami, then I'm going to have a lot of time for discussions, please. Now I'd like to ask Dr. Gerd Daniel Pust, the director of the Surgical Intensive Care Unit in Miami, and one of my greatest friends, a trauma surgeon here, to present the data from Miami. And then after that, we're going to have some discussion. Dr. Pust, thanks for the last minute availability to do a presentation, replace Dr. Scalia that had his family issue. Thank you, Dr. Pust.
Thank you very much, Antonio. I appreciate it. Yeah, Tony literally called me like 15 minutes ago and said, "Hey, can you help out and present very quick?" So I'll put some slides together. First, I want to give a quick updates on our current data situation in Florida and at our hospital. And then I will talk a little bit about challenges at our institution as a major safety net hospital, doing a trauma surgery, doing transplant care, and so on. In the time of this pandemic, we faced some extra challenges there, and I want to discuss them with you. I will try to be brief so we have more time for discussions, and I'm going to go ahead and share my screen very quick with you. Are you able to see my slides, Antonio?
Yes, go ahead, please.
Okay. So most of you know this dashboard from Johns Hopkins University. I took that screenshot literally just like 20 minutes ago. So those are up-to-date numbers. And now, unfortunately, worldwide, we're close to 12 million confirmed infected COVID patients now. The United States just passed 3 million, followed by Brazil behind just with 1.6 million. So unfortunately, the numbers continue to go up at a very fast pace. Over 500,000 people have died from this disease worldwide already. The next slide shows you that Miami-Dade County, where our hospital is currently is located, is currently the number 6 on the list of the counties in the United States with the highest number of COVID patients, over 50,000 confirmed cases in our city, in our county. Rapidly increasing and one of the major new hotspots, unfortunately, in the United States. Those are the Florida numbers. Just like literally like 30 minutes ago, you can see that the total cases in Florida are now over 220,000 and over 16,000 hospitalizations since the COVID outbreak in our state. Over 3.8 thousand people have died in our state. You can see here the lower graphic, the yellow bars shows the daily new infections. Throughout May, when we were in lockdown, our daily numbers were usually around 500 or less. Since the state reopened, we had a significant surge of cases. Pretty much 3 weeks, started pretty much 3 weeks after the state reopened. And we have gone as high as 11,000, 11,500 cases in the beginning of July. And we continue to have high cases up to 10,000 additional new cases every day. We notice also that there's a significant change in the age group or age distribution. You can see on the top graph that it's more younger patients now. People in their 20s, their 30s, their 40s. Those are the populations who tend to do 2 things. They go back to work, but they also go out and socialize. And we saw a significant shift in the age population. In the beginning, in March, April, it was mainly elderly people and nursing home people, and it really significantly changed towards a younger population. You can see here, this is the slide for Miami-Dade County. So this is just our area. Right now we have up to 3,000 new cases every day in Miami-Dade County. And we see the same in the change in hospital admissions. You can see in the beginning of March, that's when we started, we had single-digit numbers. The blue graphic on top is for Jackson Memorial Health System. We have 3 hospitals. The main one is the Jackson Memorial Hospital, is the orange curve, and the gray and the yellow one are Jackson North and Jackson South on the other side of our city. And the blue again is the total numbers, and you can see how throughout March and April, our numbers were fairly low. We went up to like 158, and then it dropped with the lockdown, but it never really went very low. So what happened on reopening, we saw a drastic surge. So you can see now that as of today, we have 337 inpatients in our system, Jackson Health System, which is 3 hospitals, 337 COVID patients. So Same, we see an increase again in mechanic ventilation. So the blue curve is for the health system. The orange curve is for Jackson Memorial Hospital, where Dr. Marttos and I are working. And you can see that in the beginning of April, we are up to about 58 patients under mechanic ventilation, and it dropped all the way down to 10 patients, and now it's going up to 58 as of yesterday, again for the whole health system. We transitioned to try to use more non-invasive ventilation support, mainly high flow nasal cannula oxygen. And so we have been able to have less patients on mechanic ventilation, but that does not mean that they're any less sick than they used to be in the as compared to the beginning of the pandemic. Again, the trend continues to go up throughout the months of June, every day increase in in-house patient population in our facilities, and continuous increase in need for mechanic ventilation and ICU beds as well. You can see like this graphic is about 5 days old. At that time we had up to 180 ICU patients, 70 ICU patients and 180 non-ICU patients in our system. This has already changed. I will give you some more data in a minute. Again, the same what we see in the communities, younger patients. We also see that in the hospital. Much more younger patients now admitted to the hospital. We see young patients who are critically ill, some of them on mechanic ventilation with no prior medical conditions. So it's just a question of how many people get infected, and a certain percentage of those patients will get critically ill and severely ill, requiring critical care support. Again, here on this graph, you can see also the shift from towards a more younger population. You can see that we also have some pediatric patients in our ICUs, and we had recently lost a child to COVID in our hospital as well. So it's not just a disease for adults. This is a graphic is a little bit hard to see, but you can see all the red hotspots are like certain areas of higher numbers or outbreaks within our city. You see the big red area is downtown Miami. That's where our hospital is located. It's also where the airport is. A lot of cases just around that area, but then there are other hotspots north of our hospital and down south where Jackson South Hospital is located. I'm going to switch slides very quick. I want to talk now a little bit about challenges we have at our hospital. Again, our hospital is a major level 1 trauma center, as well as a major transplant center. We are performing highest number of organ transplantations in the United States, kidney transplant, liver transplantation, and multi-organ transplantations. And with that, we're providing the surgical critical care for those patients and have additional challenges in those patient populations with transplant patients and trauma patients arriving at our hospital with COVID. You can see here, this area is, this is a Jackson Memorial Hospital campus. In the front here, the lower building is the trauma center. And then here in the back, several different towers for patient and floor beds.
Then you still see the first PowerPoint.
Oh, hold on a second. You see it now?
Yes.
Okay, sorry. Yeah, so you see on this image, again, this is our hospital campus, and the front here is the trauma center, and then in the back, all the different hospital towers. We have over 1,500 beds together, over 12,000 employees at the hospital. We have over 270 ICU beds. That was before we started with COVID. Now the numbers are higher because we converted some patient care areas to additional ICU space. We perform over 20,000 surgeries a year, and we also support the medical support for the JS system and so on. Our first screening started, in end of January. We started to screen all the patients who come to our hospital. We had significant challenges that some of patients who tested negative were admitted to the non-COVID area in our hospital and then subsequently tested positive. And those incidents resulted that some of our staff got exposed to COVID as well. And those are the challenging cases. It's not so much the patients we know who have COVID, it's the ones who get admitted, who come to the hospital for other reasons, other diseases. And on screening, we're not identified as being COVID patients, even so we test every single patient who gets admitted to our hospital. You can see that earlier in March already, we started to do in-house PCR testing. Our laboratory was very aggressive and advanced in rapidly requiring testing platforms, different methods of platforms, different PCR testing. And we were able to very early on do a large-scale testing for our facility and also for the University of Miami hospital across the street, mainly PCR-based. Now, this is our trauma center. Again, one of the major level 1 trauma centers in our hospital system. It was opened 30 years ago, and we see over 5,000 severely injured patients per year. We basically provide most of the level 1 trauma care for the city of Miami, but we also get multiple patient transfer from other hospitals as well as international transfers from the Caribbean, which is also additional patient load at this time. We have a high number of penetrating trauma requiring immediate surgical interventions. And we have seen over the last weeks a significant increase of COVID patients in our trauma population. So we see a lot of patients almost on a daily basis who come in after a motor vehicle crash or gunshot wounds. There's no COVID symptoms, but when we test them, they test positive for COVID. And that's just a reflection of the high number of community prevalence at this time of the disease in our city. Again, this is the area where the ambulances arrive and where the trauma patients come in. And then this is the trauma resource area where we enter. And we basically kind of redesigned how we do this with COVID patients now. So at the beginning we had, realized that we have to assume that every trauma patient may be positive for COVID until proven otherwise, right? Because at that time, we don't know. And with trauma care, often we have to do procedures such as intubation, chest tube placement, and so on. So there's significant risk of aerosolization. So early on, we decided that we're going to treat every trauma patient as if they would have COVID. So the trauma team was always dressing up in full PPE, meaning like N95, goggles, eye protection, and so on, in order to avoid exposure of the stuff. Those are our trauma base. They all look, we have 6 of them. They all look the same basically. And when the team takes care now of the trauma patients, we using full PPE. We also addressed how we change our operating room. We have 6 operating rooms for trauma. They're dedicated for trauma care. We converted one of those operating rooms into a negative pressure room. So we're doing now heavy penetrating trauma, which needs immediate operative intervention, like the gunshot wounds and so on. They go straight to this negative pressure operating room, and we assume that they have COVID. And so we bring the full PPE while we do our surgeries. We're using the negative pressure room to make sure to have good air exchange and lower the risk of aerosolization and transmission during surgery, and trying to protect our surgical staff. And then in the intensive care units, we have challenges now, because those trauma patients, where do we send them, right? So in the beginning, we send them to the COVID units, but as you can imagine, some of those patients are critically ill. Some of those patients require multiple operations. They have open abdomens, they have severe traumatic brain injuries and so on. And it's difficult to treat them in a medical ICU for COVID, because the main problem is not COVID, the main problem is the injuries they're having. And so we started to have a dedicated area in our trauma intensive care unit, which we turned into negative pressure rooms, separated from the rest of the population, and providing trauma care over there for those patients. This is an image at Jackson South Hospital, one of our satellite facilities. As Dr. Francesco Vaia mentioned here too, the COVID intake is completely separate from the rest of the emergency room at that time. There's a tent outside where all the patients who had symptoms of respiratory illness were tested and treated, separate from the rest of the emergency room. Once our initial COVID numbers went down, that tent was then subsequently taken down. And now with the new surge of new COVIDs, actually this tent is going back up again outside the emergency room to create this additional space to take care of COVID patients. The trauma base in that hospital, which is also a level 2 trauma center, which is covered by our group, is the same. We treating every trauma patient who comes in our Jackson South facility as if they would have COVID patients, utilizing a full PPE. We changed a little bit how we handle those patients when they come in. We try to minimize the size of the team taken care of, especially if we do endotracheal intubation. We ask everybody to step out, but the anesthesia team performing the intubation, and then the rest of the team comes back in after the aerolizing procedure is completed to avoid or to minimize the amount of people getting exposed to virus at any given time. You can see here we're using different types of protection. Most of us are wearing the regular N95 mask. Some of us have acquired also those different masks with silicone masks where you can attach the filters externally, or the mask with full face shield. The hospital systems acquired now PARPs, so those are those ventilated full head masks. We had a lot of challenges with fogging of our gargles and shields when we operate, especially in the trauma rooms. The temperatures are very high, so that the patient doesn't get hypothermic, but then the challenges are that we're having issues with fogging, and then you cannot see when you operate. So the PARP systems will help us to hopefully avoid those issues. We have pre-packed PPE kits. Basically, they come in those plastic bags in order to control our PPEs, and that we only use them for the patient we really need to use them. So each kit has the full, gear, N95, a bunny suit, shoe covers, head covers, and goggles, and so on. You all know I have this pretty much the same. A lot of us using, in addition to the goggles and the mask, a face shield to protect our PPEs from, splashes of fluids and blood and trauma care. And then we wear this bunny suit, and on top of that bunny suit, we then wear the surgical gown. We have dedicated transportation teams in the hospital who transport those COVID patients. You can see also that they're in full PPE, and we usually have a member from the security team walking in front of the team, getting the elevators and clearing out the hallways that other people don't come too close, and also to make sure that the team, which is obviously contaminated, is not touching other surfaces like the elevator buttons and so on. In the operating room, again, anesthesia team here you can see is intubating a patient. At times they're wearing these extra striker head covers. That was early on in the case. Most of them now just wearing regular N95 and goggles. And again, this is in a negative pressure room done. And then again, this is, a bunny suit, a layer of gloves, and we just do, basically disinfect those gloves and then put the surgical on top of it and operate on those patients. Biggest challenges are in our ICUs now. We have basically a large group of medical COVID patients, which are taken care of by our medical critical care colleagues. We converted multiple medical ICUs into COVID units in medical ICU A and B. The cardiac ICU is completely transformed into COVID units. Central 6 used to be a 20-bed step-down unit, which is now also a full ICU unit for COVID, dedicated COVID. All those rooms were converted into negative pressure rooms. We think it's really important to have those negative pressure rooms in order to minimize the amount of virus being aerolized in the air. We had the need to convert one of our surgical ICUs, half of it, the SICU-B, which is normally our transplant ICU. We converted half of that unit into a COVID unit, separated from the rest of the other side of the ICU, converted those rooms all into negative pressure rooms in order to be able to provide critical care to COVID patients who are transplant patients. So we have a significant population of patients who are either post-op or pre-op waiting for organ transplantations, critically ill requiring ICU support, but then at the same time have COVID. Or we have patients who have been transplanted in the past, they're followed by our systems for years, and now they're presenting to the hospital with community-acquired COVID, and we take them back into our transplant ICU and provide the COVID critical care for those patients with special transplant needs. Multiple floor patients, hospital floors have been also converted to negative pressure COVID areas. So again, separation of COVID patient from the rest of the hospital population is absolutely critical. The issue is we are not able to completely convert our hospital into a COVID hospital. We, as a major safety net hospital in our city. We have to continue to provide care to the non-COVID patients. So we have to basically create a COVID hospital within the hospital. We're basically running two systems parallel. In our surgical COVID unit, we also provide the ECMO care for COVID patients who need to go on ECMO. The care is pretty much standardized and the same like across most hospitals who provide COVID care. We do a lot of proning, high flow nasal oxygen, if needed mechanical ventilation, and of course different trials we are participating in, and the use of remdesivir, anticoagulation, plasma exchange-phoresis, and of course with Dr. Ricordi, the stem cell trials are done in throughout our units across the system. This is one patient room and the surgical intensive care unit. You can see in the back is the patient room. Currently, you see that we have glass doors, which is very good because we're able to look into the room and can always see the patient from the outside, which limits the amount how often you have to actually open the door and enter the room. Which also helps us to burn less PPE and preserve PPE because every time we have to go in, obviously you have to put on PPE. So we try to limit the amount of unnecessary entries into the patient room. We have a red zone, which is the patient area here. You can see the floor is marked with that. That area between the red and the yellow zone is where we're taking off the PPE gowns. You can see here the biohazard bands where we drop the PPE. And then we have here the hand hygiene area in the yellow zone where we make sure that all the proper hand hygiene is observed. And then outside is the green zone in the hallway, which is considered clean and not contaminated. Other methods we have used in order to minimize the amount how often we have to go into the room. This is an image from our trauma intensive care unit where the ventilator module, the control module for the ventilator has been separated from the ventilator itself, which you can see on the inside, on the other side of the glass door. So when we want to do ventilator adjustment changes, we can do it from the outside without entering the room. The same with the IV ports. You can see here that it was removed outside too with IV extension tubing to the patient. So we can adjust the continuous drips from the outside without entering the room. Again, reducing the number of entries into the patient room, reducing the number of exposures of the staff. This is a picture which I just took 2 days ago. This is one of our emergency rooms. Large areas of the emergency rooms have been converted into negative pressure areas. You can see here, this used to be all open areas, open beds. And now you can see that here makeshift plastic drapes were installed, and you can see how they bend inside because the whole area is basically negative pressure. And behind all those plastic curtains are currently COVID patients. Just a reminder, you know, a lot of you who taking care of COVID patients, you see this all too often. This is a patient who had a kidney transplantation done 3 months ago. He was at our hospital and had a COVID, and you can see on this X-ray, you see some fine patchy infiltrates. The next X-ray is just taken 24 hours later. You can see how it's worsened. And within 48 hours, we have a complete whiteout of the lung, and obviously difficulties to ventilate those patients. And with that, I want to complete my presentation. Again, you know, the main challenges we had in our system is to take care of the patients who come for other reasons, who don't come for COVID, right? The medical COVID patients we know of, we identify them, we put them in the COVID units, we have the staff trained how to use the PPE to take care of those patients. The challenges we had were patients who were admitted to non-COVID ICUs or floor areas, had a false negative COVID test, and then subsequently turned positive. And then during that time, they were exposing other patients, and we had patients who got COVID or employees got COVID. So those are the challenging patients. And then the patients who need specialty care, trauma patients, transplant patients, surgical patients with COVID. And that's why it's difficult to really completely separate providers taking care only for COVID and providers taking care of non-COVID patients. For instance, when we're on trauma call, when Dr. Marttos is on trauma call tomorrow, he's going to take care of probably 10 non-COVID patients, but he also is going to have 3 COVID patients, and that's all in the same shift, right? So there's always this risk of cross-contamination and so on, and I think that's a topic we need to discuss today.
Thank you, Dr. Pust. Great presentation. Showed the problem that you're having here right now in Florida. I'm going to go straight to Dr. Michel Aboutanos. Dr. Aboutanos, could you please moderate the discussions? We have already 3 questions on question and answer box. Yeah, I have a lot of discussion to do with Dr. Francesco, Dr. Pust, and Dr. Ginsburg. So, Esteban, please.
Unfortunately,
Esteban and Michael.
I'll have Dr. Fognini, if you could take over, I'd appreciate that. Esteban.
Okay, Michael, welcome.
Thank you. Sorry.
Okay, so yes, so I'm here. So let's cover some of the questions, or we're gonna look at the questions from the panel. Okay, so I'm just gonna go with some of the questions from the participants here. Question directly to Dr. Francesco. How did you screen patients for COVID, non-COVID, and how did you ensure that the screeners were not infected?
So Francesco, una domanda per te, se dice how do you separate COVID from non-COVID patients and how do you make sure that the screener are not infected? Is that the question?
Yes, that is a question.
Dice come separi i Covid da non-Covid patient e come se ci si assicuri che quelli che fanno lo screening non vengono infettati.
Ho cercato di... allora, in una prima fase l'ospedale era Covid e non Covid.
The first phase, the hospital was Covid and non-Covid.
Questa fase è durata molto poco, pochi giorni, perché subito dopo l'ospedale è diventato solo Covid. E
immediately after a few days, the hospital became only COVID, so they didn't have any more the problem.
E sono stati dedicati personale e reparto solo a Covid. In particolare sono stati dedicati i reparti che avevano stanze singole all'inizio a pressione negativa. Questo è un presidio assolutamente indispensabile perché nelle stanze a pressione negativa è impossibile infettare ed infettarsi.
So they practically implemented very fast the negative pressure rooms where it's impossible to get infected or infect others.
Quindi praticamente i pazienti nell'ambito della rete, nel network, abbiamo mandato via i pazienti non Covid ed abbiamo lasciato in queste stanze a pressione negativa solamente i pazienti Covid.
So all the rooms were negative pressure and they send away all the patient non-COVID, maintaining in the hospital only COVID patients.
E il personale è stato strettamente dedicato. Chi si occupava dei pazienti Covid si è occupato solamente dei pazienti Covid e basta.
The personnel was extremely compartmentalized and dedicated. Who were taking care of COVID patients were doing exclusively COVID patients and no one else.
Si tratta di un principio generale: strutture dedicate, percorsi dedicati, pazienti dedicati.
It's a general principle: dedicated structure, dedicated pathways, and dedicated workers and dedicated patients.
E poi una sorveglianza attivissima della direzione con sopralluoghi per controllare che le linee guida venissero e queste disposizioni venissero applicate.
A very active, rigid implementation of the guidelines and the rules by the health direction with frequent monitoring visit and audit to make sure that these things are implemented.
Ovviamente questo insieme alla formazione continua sull'uso corretto dei presidi, le maschere e quant'altro.
Together with a lot of teaching and training. Okay.
I think the question was more on the lines of how do you screen the patients, and I think what they're asking is if you do RT-PCR, if you do CT, if you do ultrasound, and how do you screen the people who are treating the patients? And this goes to a separate question too, which I'll follow up, which is what is the routine? When do the physicians, nurses, healthcare providers get screened within the system? And what is your screening technique? I think that answers two of the questions here.
Allora, la domanda è come si effettua lo screening con che test? Fate l'RT-PCR per il virus, il swab dal naso e faringeo?
Per il personale o per i pazienti?
Per i pazienti, e poi con che frequenza e che test di screening si fanno nel personale per il monitoraggio?
Ok. Il personale si sottopone a 2 screening. Il primo screening è serologico o per prelievo endovenoso o per capillare, e in caso di sieropositività, quindi IgG o IgM sopra il cutoff, fare il tampone nasofaringeo.
So, il personale fate prima gli anticorpi del tampone?
No, la seroprevalenza, il IgG, anticorpi. Il prelievo venoso oppure da capillare, ok? La determinazione del titolo anticorpale.
They do the determination of the antibody titers, IgG and IgM from a venous sample or from capillary blood.
Ok, in caso di superiore al cutoff di fare il tampone nasofaringeo.
And then if it's above the cutoff, they do also the nasopharyngeal.
Ok. E accanto alla sorveglianza, come ho detto nella presentazione, l'autosorveglianza, c'è questa diciamo sorveglianza generale, sottoporre a screening il personale ogni 45 giorni.
Every 45 days the personnel get screened again.
Okay, very good. Thank you. So I'll raise another question that comes up here, and this is for my good friend Dan Pust. Nice presentation. Do you expect theater room increase of infection, and how? So I guess what they're asking is, are we going to see more patients going to the operating room that are going to be positive for COVID? Dan.
Yes, Esteban, thank you. For sure. I mean, literally, and I think Tony can attest to it too, like pretty much every trauma corner we have surgical patients or trauma patients who are COVID positive and need operations. So yes, the number is still going up. Apparently it's with the increase in our community prevalence, and it's a huge issue. That's why we assume that every patient who comes in who's a trauma patient, where we cannot wait for the test results to come back, you know, we test every patient. And we do the rapid PCR testing, which sometimes comes back in 15 minutes. But, you know, with a gunshot to the abdomen, you cannot wait 15 minutes for the test to come back. So we assume they have COVID until proven otherwise. And we take all the precautions when we take them to the dedicated COVID negative pressure trauma operating room and wearing the full PPE. And, you know, many of them come back not positive, and we're happy, but, you know, every day or every other day, we have somebody who is positive. And most of the time, they're not symptomatic. And in regards to, you know, testing the stuff, this is a huge topic we have been discussing at our institution for a long time too. And it's very difficult, right? To first of all, you know, we have up to 15,000 employees. So just from a pure logistical point of view, to test everybody frequently, let's say, like, how often you're going to do it? Every week, every other week, every 3 weeks, what combination you're going to do, PCR and antibodies. We had several problems with the antibody test, that sometimes you have patients, they have positive PCR, they have obvious COVID, you check for antibodies, the antibody test is negative, right? So, and the antibodies take time to become positive too, right? For, you know, even for the IgM, takes, you know, 7 days, 10 days to become positive. Some patients seem to have almost no antibodies or very low titers. So it's not a good screening tool either. You know, like the PCR is pretty good, got much better compared to the beginning, like 3-4 months ago. But it's not 100%, right? So once in a while, you're gonna have patients who have a negative test, and the repeat test 3 days later will be positive. We had some exposures in our surgical ICU early on, which as a result, we triggered to test the entire ICU stuff. So we sent, you know, 100 nurses, doctors, everybody who was working in that unit to get screened. And, you know, we found up to like 4 or 5 nurses out of 100 people and techs who tested positive. The challenging thing is you don't know if they get it in the hospital, if they get it in the community with a very high community prevalence. You know, some people also get it outside of the hospital. And so we're discussing, you know, how you screen the employees. You know, are you doing fever checks and symptoms checks every morning when everybody enters the hospital? Well, the problem is over half of patients or half of people who have COVID have 0 symptoms whatsoever, right? So it's not very effective either. So it's challenging, you know. Maybe you can tell me what you do right now in Bolivia regarding testing of staff, routine testing.
Yeah, currently in Bolivia, we're only testing people who are symptomatic. We're doing RT-PCR on them. It's evident that in the community, a lot of people are testing antibodies, and the quality of the tests I mentioned beforehand are questionable. So you have people who come back IgM, IgG positive, and a week later they get and they're all negative. So the value and the quality of testing is a major concern in Latin America. I would presume that in Italy and the United States, there's much more control of that.
Yeah, Esteban, yeah, I have a question for Dr. Ginsburg, Dr. Francesco. So, Dr. Ginsburg, so I know that you are very concerned every time I have a trauma patient, every time you know the physicians share call rooms, etc., etc. Dr. Francesco and Dr. Ginsburg, any rule for UV lights? Any how to protect the healthcare professionals? How to sterilize the big rooms, etc. Trauma bays, etc. Ginsburg, your comments first, and then Dr. Francesco. Any rule, any special thing with UV lights, or any other technique to do
well,
this?
as you know, Antonio, the focus of this discussion was basically with regards to safety within healthcare workers and how to keep the spread down. And as you know, the first thing that I did was in our on-call rooms was buy UV lights to sterilize the rooms since we use them a lot. But there is a challenge to UV lights, and that is that UV lights, as we all know, have a safety issue in that the current UV lights that we have penetrate the stratum corneum and are associated with skin cancers and cataracts. However, there is now a future, which should be already in November. There is one company by the name of Ushio from Japan. I think they already have these up in Japan. There's what is called FAR UV. The FAR UV is a 222 nanometer UV light as compared to the 250 nanometer UV lights that are being used in sterilization in hospitals, and that's been used for a while. The beauty of this is that it has been shown to not penetrate the stratum corneum. There's been plenty of animal research, and the FDA has now cleared it. They are coming out, at least in the United States, with distribution, and only will be distributed to hospital systems because there's not enough ramp up in the equipment. So this is something in the future. What we are doing at Jackson right now is something of interest also. In fact, this week or next week, there is a company, Surfacide. I actually have a conference call I'm supposed to have a conference call in 3 minutes with them at 2 o'clock, but I postponed it till 2:30 because of the length of this conference. But Surfacide is coming here to evaluate. They actually have what is heat-censored UV lights, the current technology of UV lights, which are on the computer keyboards, and also they have a air handler for UV lights that are contained within the air handlers. So because the UV light, what it basically will be doing, and the FAR UV, it sterilizes all aerosolized, all suspended virus, all types of virus. It's already been shown it kills all the viruses. And at the same time, this technology that we have available right now is to prevent spread between people that are using computers and people that, and in the ICUs. And actually, you could probably put them all throughout the hospital for the air handlers, but there is a certain expense to that. So that's with regards to UV lights. In case they call me for this other conference call, the other future, and I'm talking about near future because it could be done already, is there is an Israeli company which mixes metals like copper, which we know is virucidal, and they mix it into a kind of a paint which lasts a year, and they spray it on all furniture throughout, throughout the walls to prevent virus from spreading. So these are two very significant technologies that are available, at least with the unsafe UV light, but now are coming on for the future within the next few months. And I think these will be throughout all our hospitals, airplanes, all public spaces, restaurants, to control the spread of not only this COVID, but any future virus. Thank you, Antonio.
Do you know what is the name of the Israeli company?
Yes, they're called Biodefense. I've already gotten in touch with them, and Camillo, they've been using this technology in food plants because it kills bacteria as well as viruses. And Dr. Abo is aware of them. We're trying to get a call with the consulate. They were supposed to get me in touch with the president of the company.
Right.
Okay, I think there's another question about ambulatory treatment. So I know here, at least here, every time we go to see a physician, he had Vaia in the front of the clinics. They measure temperature and make some questionnaire, ask you some questions, and then you need to wash your hands, alcohol gel, put a mask, then you can go to the physician. But if you have fever, etc., you're not going to go to the office. Dr. Vega, any comment, please? Your comments regarding how to protect the healthcare professionals, please. Dr. Felipe Vega, I think you're muted. We just lost Felipe. Michael Aboutanos. Dr. Aboutanos?
Yeah. Sorry, I was unmuting myself. So I think these are all very, important, I guess, both recommendations. This is a very significant for us. It's both changing on the personal level and also changing on the system level, as has been mentioned before. And we have, for example, ourselves modified the entire process down in the emergency room here at VCU in Virginia, and also in the operating room, dedicating specific operating room for the COVID positive patients. But everybody's trained. We created videos and training, and really shared all that. Specifically, I think in trauma, when we're very busy and we're coming to see patient, we have, and all depend on your resources. We created monitors, personnel who are monitors, who would actually watch you if you're doning or not doning, watch you if you're jumping in on a trauma patient and don't put your N95 on. And so I think those are very important measures, because it's everybody will, you could sing together or survive together. It is really a herd mentality with regard to this. And this is what we have instituted. And we did that at the very heart of the crisis here in Virginia, but then now it's on a sustainable aspect, and it happens all the time, where we have, where we've been stopped to say, no, you must wear these additional protective devices, or you didn't do this right. So kind of check and balances becomes something very important, and empowering people who, that everybody is incredibly valuable, not just kind of the surgeons, and the ability to kind of give the power to that co-pilot to tell the pilot you're going the wrong way. So that aspect, I think, is very important, and that goes back to the personal protection that needs to happen. Kind of looking out for who is your, who's your brother, who's your sister, with regard to this, and making sure that that happens. But it does have to flow from the top. Initially, when we first started, we had some issues with not having enough PPEs, etc. Now we're in a different phase. We're more of an endemic phase where there are enough aspect. So this is kind of what we have instituted, very similar to everybody else. And this session has been, and this conference has been very beneficial for us to transmit that information to everyone as well. Only question I had kind of from everybody is with regard to the call room. You know, when you're on call and then somebody else is coming in after you, or you're coming after somebody else, beside the UV light, which we have not done that actually, what others have done. We've done just changing the sheets and doing all the stuff, and our housekeeping also part of the whole solution. I wonder what everybody else has done with in-house calls.
Michelle.
Yeah.
It's Enrique, and then I'll listen to the others. In the Jackson South on-call rooms, I've gotten the big buckets of the detergent wipes, and most of us use those to wipe down. But the beauty of the UV light, first of all, I bought those personally. The hospital did not. They were very inexpensive. They run about $90, and they run for 3,000 hours. And usually an on-call room requires only 30 minutes of being on. And so I tend to, the way I use it, and everyone uses it differently. I know Antonio uses it. I tend to use it. I turn it on when we change shifts, and I go up to round on patients, and after the room has been laundered, because this way the UV light, even if the ancillary workers are using gloves and masks, I like the idea that after everything's been done, I put the UV lights on, and then I feel much safer. Not only does the UV light sterilize surfaces, but it sterilizes what now has been shown to be not only the aerosolized suspended virus, but just from breathing, you have suspended particles that stay for a long time in the air, and those UV lights do sterilize those viruses. So it's what?
A question I have, sorry, because you know, Dr. Fanina and I have discussed this before. Do you see this as a high-income country solution that's not applicable to low and middle-income countries? In as far as if they have to prioritize, what would they use to protect their personnel? You know, would you? What would be like, for example, Esteban? What would be your decision here? What would you use first? Would you use mask stuff, or would you go with the UV light that seemed to kind of affect more than one person?
I think that what Enrique is proposing there with the UV lights is very interesting. There have been offers here for UV lights in Bolivia, but again, most of them are not from the mainstream, and I'm kind of questioning the quality. What we've encountered is actually, and you guys mentioned that beforehand in call rooms, we had a group of residents who got infected, and it's because they did not keep social distancing within the call room, which was an issue. And the other issue is that despite the mandate for housekeeping, sheets were not changed between shifts. And that is a major problem. So I think that when it really boils down to everything, it's all about educating the staff. It's about implementing just basic common sense measures. It doesn't cost much to wash sheets. So housekeeping has to understand the importance of cleaning the room appropriately and changing sheets with every single shift. Because evidently if a resident sleeps in a bed and then one of the partners comes to you and though they've made the bed, the risk for contamination is there. I think the UV lights are rather interesting. And to further your discussion, Mike, in my hospital, we're going away from N95s, and we're starting to use reusable elastomeric face shields, if you will. So most of the surgical team is going to purchase 3M face shields. We find that we just buy it ourselves. They last for a long period of time, and we're not wasting N95s, which are hard to come by and eventually very expensive. So I hope that helps to answer some of the questions.
Yes, if, if I may, we have now also multidisciplinary team between physicians, scientists, and architects on how to design and improve safety, not just in operating room or in patient's room, but also in houses and apartments. And I think that the fact that you have aerosol spreading of the virus that was underestimated completely at the beginning of the pandemic is another important factor. And now there are systems also for UV light within the air conditioning duct that don't expose people to the harm of the UV light that could be considered. So how you try to clean also the air, that there are differences in air conditioning depending how the hospital have been built, or any apartment building for that, that if part of the air is recirculated, there have been the famous Amoy Garden since the SARS-2 epidemic was published in New England Journal of Medicine and was taken again by much newer paper in New England Journal of Medicine, how the transmission can occur one room with the other, one apartment, one floor, through both the conduit on the toilets and the conduit in the air conditioning. So I think that the air transmission should be seriously considered. And for example, I bought myself, not through the hospital because it takes too long, but there is this medical jet, have these devices that look like a big tea machine teapot that disinfect areas of either 100 square meter or 1,000 square meter with a dry particle aerosol that lasts like 20 minutes, and you can recondition and sterilize completely an entire operating room. They use it in ambulances, in trains, in room of hotels, and it could be because the UV light will take the first surface. Like when you sterilize a mask with UV light, you would have to do half an hour one way and then flip the mask and do the other side. Otherwise, you will not sterilize deeper than a certain layer. So some of this aerosol and air distributed disinfection of an entire space could become, I think we need to use combination strategies, will not be just a single solution.
With regards to what Dr. Fionini was saying, Antonio and Michelle, and through all our international contacts, I would love if you would be able to get someone from Taiwan to come and speak to us on this. I don't know if any of you have actually looked at the numbers in Taiwan, but Taiwan, a country of 25 million, just never stopped their economy, and all they did was social distance, and everyone wore masks. All the kids, all the adults, and kids went to school. And with that approach, they've only had close to only 500 total COVIDs and like 7 or 8 deaths. Now, this is a whole country. So, yes, we have all these other techniques, but as everyone knows, Dade County numbers have just exploded in the last week. And I drive around the city and no one, 80% of the people are not wearing masks and social distancing. But I would love to know a little bit more of what's going on in Taiwan.
Yeah, I think the problem in South America, some places where not people were compliant to social distance and masks. And again, Miami, we are doing great. And then once the reopening, a lot of people thought it was over, went to restaurants, parties, pool parties, etc. And then we are right now.
Sorry, just to add to Enrique's, we had the discussion last week from his, which, they were able to get the numbers down. And the question is, how come France was able to keep their numbers down? Yeah. And it was the exact same measures that you just mentioned with regard to what Taiwan did. Just, very strict social distancing and very strict wearing masks. And we talked about the cultural influence and how this cannot, in some areas it works better or not. But we will definitely work on getting a speaker from Taiwan. It's a good idea.
Yeah. Or South Korea. South Korea, they had like a peak in the beginning, and then they were able to control everything. But Fanny, you have some comments regarding altitude and other comments, please?
Yes, actually, if I can, they can allow me to share the screen. I'm not as proficient as Dr. Pust is putting a presentation in 20 minutes, but it's just 2 slides. Dan, you did a great job. So Enrique brought, Dr. Ginsberg brought up this question a couple of weeks ago about altitude and the protective effect of altitude. And let me see if I can share my screen here. Yes, so here we go. All right, and I was going to add something else here, but let me just show this. So what I'm trying to show you is 2 dates in the Bolivia registry. And to the left, you see June 10th. And what I want to highlight here is that at that point, we had 630 cases in Bolivia. So roughly a month later, on July 7th, we have about 1,000 cases. Back when I spoke with you, about 70% of the cases occurred in Santa Cruz, which is this area right here, which borders Brazil. It's part of the Amazon basin. And the Altiplano is really what you see: La Paz, Oruro, Potosí, and a little bit Cochabamba. Cochabamba is about 2,000 meters above sea level. La Paz, Oruro, and Potosí are anywhere from about 3,500 to a little over 4,000 meters above sea level. So this is very high mountain range. What you can see is on the 10th of June, there are 842 cases in La Paz. Currently, there's 4,800 cases. And what I'm trying to state is that Santa Cruz has roughly doubled the number of cases they've had, from 9,500 to 22,000 cases in the last month. But La Paz has gone from 840 confirmed cases to over 4,800. So over 5 times the numbers. So I think that what's been happening in these countries, they made the example of Ecuador with Quito having less cases than Guayaquil, the case for Tibet and China having very little cases. The reality is Altiplano is isolated. And I think what we're seeing here is just a shift in the curve, very similar to what's happening in the United States. I would equate Santa Cruz to New York City, and La Paz and Cochabamba are becoming Florida, Arizona, and Texas in the United States. And I think that altitude does not confer any type of protection, and rather it's created a hindrance in my country because people thought that they were protected and they did not appreciate social distancing and doing the right thing. And they will become the epicenters, unfortunately, of the disease in Bolivia. And I perceive that things in Santa Cruz will start to improve, although I suspect that we'll still be living with a high infection rate over the next 2 months because the government, because of social pressures, has decided to open up the economy. So there is no restriction anymore, lockdown as we had up to 2 days ago. And I suspect our cases are always going to increase. So I just want to share that with you and take away this sense of altitude being protective.
Thank you, Esteban.
Very much appreciated. And I actually looked at that. It started out that way. And then I was thinking, well, what do we know about high altitude? There's a higher exposure of ultraviolet rays. But obviously it has not panned out as what you're, from your data.
Yeah, at least the numbers in Bolivia haven't panned out. And I think that if you look at Ecuador and Bolivia, the phenomena is that Guayaquil and Santa Cruz are more affluent and more cosmopolitan cities traditionally. And what that means is you have a higher number of expats or international people in these communities, and you have a higher number of people traveling outside of our respective countries. So that gives some degree of protection to Quito and to La Paz that have less travelers and less foreign people coming in. But since we failed to restrict travel within the country, and that's something that China did, what we're seeing now is cases from Santa Cruz being exported into Oruro, Potosí, and La Paz, and their numbers increasing dramatically.
Got it.
Thank you very much, Esteban. So I believe you are all right, ready to finish. I would like to say thank you very much for Dr. Camilo Riccardi for bringing Dr. Francesco to this presentation. It was very important to hear what he did. Unfortunately, you have a lot of people being contaminated, so you lost some good friends in the United States and also in Latin America. And this topic was very important Dr. Pust, thank you very much for helping in the last minute. Dr. Ginsburg, it's always a pleasure to have your comments. Dr. Felipe Vega went to the emergency. Esteban, you still has a lot to do with the Panamerican Society. I know Miami has been hit hard right now. Florida has been hit hard, and then among other states in the United States. And I know that some places in South America are reopening, and maybe it's gonna still happen for some long time. I'm gonna always be here to try to keep helping and try to learn with each other. Dr. Aboutanos, your final comments, please.
As you mentioned, Antonio, just thanking everyone and all their time. Since we first started, been able to share information, and above all know that we have to protect ourselves, protect the team in order to be able to be available to protect our patients. And so the best we could do is right now is share information, and appreciate everybody's time and the fact that we're all in it together. There's something very important about solidarity in the face of this crisis. So we a lot of gratitude for everybody who took their time to contribute.
Thank you very much, Michael. So in name of the Pan-American Trauma Society, the American Association for Surgical Trauma International Relations Committee, the World Coalition for Trauma Care, University of Miami, and Virginia Commonwealth University, VCU, I'd like to say thank you for all the panelists and presenters today. We learned a lot. We need to stay together. We need to protect ourselves. Because protecting ourselves, we can help our patients. Please stay safe. Thank you, Valeria, Gary, Stephanie, Gladys, to work to make this series of webinar happen. The video recording this meeting going to be available at the Panamerican website next morning. Thank you very much, all. See you next week. Take care.
Bye. Take care.
Bye. Thank you.
Thank you. Bye-bye.
See you.